So now we're going to move on to case 2. And case 2 is about Lois. And I believe there's a typo in the version that you're seeing on the screen now, but it's a very minor one. So I'll just verbally mention what it is. So, and I'll read the case out as well, just to make sure that we're all on the same page on this one. So Lois is a patient with early dementia, and she has been cared for by Dr. Chia for 2 years. She's recently become ill and requires intravenous antibiotics to treat the infection. However, the treatment has the potential side effect of affecting her kidneys, which is partly aggravated by the other medications she is regularly taking. In the worst case, the effect on the kidney is permanent and she may require lifelong dialysis. Lois fluctuates in and out of lucidity and is sometimes hard to tell when she's speaking with a clear mind. Dr. Chia speaks to Lois and her family about the severe infection, the threat to life, and possible effects of the medication. The family accepts that Lois needs to be treated with IV antibiotics. Dr. Chia does not mention the specific risk of needing long-term dialysis for kidney damage because it is a very unlikely scenario, less than 1%. Lois herself seems hesitant, but does not complain. A note in her clinical file from a previous doctor many years ago states that she's averse to the prospect of losing any sort of bodily function as it makes her less of a person. Following treatment, Lois recovers from the infection, but develops complications and requires dialysis. Her family then files a claim against Dr. Chia for failing to advise them of the potential kidney damage. Lois herself states that she has always been against such treatments. Okay, so those are the case facts, and perhaps we can get the ball rolling with a question. And of course, participants, please do keep your questions going in the Q&A feature. So the first question that we've got for everyone is, if Dr. Chia judged the risk of kidney damage to be low and would not ordinarily advise the patient about it, what circumstances would give rise to a duty to advise the patient about the risk of kidney damage? Okay, maybe I can direct this question to Vanessa first, if that's okay, Vanessa.
Thanks, Sumi. So in this question, which regime we're under actually matters. So if it's under Hitchcock, I would think the risk would need to be disclosed because the Court of Appeal in Hitchcock does say that if it's a long-term risk and it's could result in severe consequences, then that is something that would need to be disclosed. Under Section 37, we then move on to whether, pursuant to peer professional opinion, that is a risk that would be disclosed by fellow professionals. So there is a bit of a difference between the two regimes. But having said that, under Section 37, if you're going to rely on peer professional opinion, then the peer professional opinion does have to take into consideration whether this is information that would be material to the patient, right? So that's where the note in the clinical file about the patient saying she's averse to the prospect of losing any sort of bodily function as it makes her less of a person, then that comes to the forefront. My own view is that that note is, I find it a bit vague. So perhaps my fellow panelists can share on what they would do if they encounter such a note, in the file, in the medical records.
Excellent question, Vanessa. From a practical point of view, certainly. Chunxia, maybe you could shed some light on that.
Okay, I think the context is very important. This case sounds a little bit like an emergency form of treatment for a patient who's very ill. That's the first thing I like to point out. The second thing will be that although the risk of this long-term kidney injury is is really low. And given the time is of the essence, I just wonder, professional opinion of most doctors would actually go to the extent of counseling for kidney damage, long-term dialysis, what are the repercussions of long-term dialysis. And the other question I have when I read the case fact is this issue of the patient expressing that she doesn't want to face the prospect of losing any bodily function. I thought it's something that's so vague, and even though it's documented, is it of any use? Because the other way that I would look at it is that saving a life is one way of trying to preserve the patient's own bodily functions, and it should not be just extrapolate into the prospect of losing kidneys. And so I just wonder whether if something is not clearly stated, whether there's another way to look at it and then use it, in fact, as justification for the doctor's treatment.
Thank you, Chunche. Dave.
Yeah, I think I'm going to just echo what has already been said, because I agree with all of it. I mean, when we think about what needs to be disclosed, severity and probability are the two measures on which we decide. But I think this case nicely highlights one fact, that what we say and what people understand may not be the same thing. And we need to be able to, it's not just, I mean, we talk about Hitchcock and the Section 37 and all this, and about information giving, but we don't actually talk about whether that information is received and understood in the same way. And we have different perceptions, then that is a fertile ground for legal disputes, right? So when you say kidney damage and they don't understand it as maybe dialysis, then you've got a difference between what is said and what is understood. I think that what Chunche brought out about how vague the statement is also true, and I totally agree that severe sepsis can cause not only loss of life, but can also cause worsening renal function. So you can interpret this, in the converse, and say that she would want aggressive antimicrobial therapy. Maybe we lost the kidney, but we saved all the other bodily functions. So that is a big gain, and that is completely in keeping with what she would have wanted. And I guess one of the learning points from this is when patients give you these sort of vague statements, it's a responsible thing to clarify. Because just, again, if all we needed was someone just to write down exactly what the patient said, then we wouldn't need somebody with medical qualifications to actually receive that information. The fact that it is someone who has got medical qualifications receiving the information suggests that, well, if someone tells you something like this, then we should probe a little bit and to clarify, what do you mean by this? What are the limits to what you're saying? And perhaps give if we understand the patient's current medical condition, maybe if she has already some chronic illnesses, to use some of the potential or likely trajectories of those illnesses to help test what she's saying, in order to make it explicit. And then your medical documentation becomes useful not only for you, but for future professionals to do this, and also important for the patient, because then it really truly is sort of preserving their autonomy when they eventually lose it. You can use this as reliable evidence to make decisions that they would have wanted.
Yeah, thank you, Dave. I think you kind of read my mind. I was about to ask certainly that very direct question about when there is a vague or unclear note in the records, what is the obligation of the healthcare professional to follow up with the patient? Because you were also talking about misunderstandings, right, between the patient and the healthcare team. So when the patient, it applies equally the other way around. So when the patient makes a statement or it says something, they may think they've been clear and you've understood the message, but actually, there has been no meeting of minds. So But this can be a very challenging thing, because people can interpret terms differently. You think you're saying one thing, but actually the message that's being received is somewhat different. I'm not sure that there is an easy way to overcome this problem, other than to spend time, which I know most of you don't have, when you are caring for patients, in order to kind of tease apart and understand a bit better what these perspectives are. But I do want to move to a question that was in the Q&A feature a minute ago. And this is kind of related to the point that Chun Jie just raised a short time ago, which has to do with whether this is an emergency treatment. So when we're thinking about it, I'll read the question first, and then maybe I'll sort of expand on what it might actually mean, or after I've read out the question. So the question says, in this case, can IV antibiotics be treated as an emergency treatment, which is meant to be life-saving, and so the level of disclosure in consent will be different? So this is quite an important question because it relates to, well, how much information needs to be conveyed, and can that be moderated or modified because it's an emergency? Now, before I open this, invite the three panelists to comment on it, maybe the first initial question to ask is there a hard line between emergency and not emergency, or would you see this more as a sliding scale? Because, for example, there could be some emergencies where literally somebody's been brought in after a road traffic accident, they're bleeding out, and obviously you're going to do everything immediately, and it's very unlikely you're going to have a conversation with anyone before that treatment is carried out, as opposed to a treatment which is, very serious and could cause, might have life-threatening consequences, but you actually have a little bit of time before you administer the treatment. Maybe if it's okay, maybe could I ask Vanessa first, perhaps for the legal perception of this before moving on to the other panelists?
So I don't think there's a legal, so what the question of whether it's considered emergency treatment, I think would be something that the court will defer to the medical opinion. Yeah, that's the short answer.
Okay. So, well, actually, can I just carry this on? Even though so in other words, what would you think the court would likely do? Do you think they will likely make a distinction between that very, need now to stop the bleeding and prevent somebody from dying, as opposed to something where you have, it's an emergency, but doesn't require such immediate action? Maybe you have an hour, 2 hours, 6 hours.
That's a tough one. I suppose it very much depends on the context, but I would argue that, emergency should not be interpreted in such a limited fashion that it's only when, a patient is going to pass on, and then that is considered an emergency. I do think in this case scenario, it's quite clear that if she doesn't have the treatment, death might be a possible consequence. So I would consider this situation an emergency, and so there would be a difference in terms of whether there needs to you need to solicit the information from the patient. I think the doctors would be justified in going ahead to give life-saving treatment.
Okay, Chun Jie, especially since you raised the emergency point earlier.
Well, I'm very glad to hear what Vanessa says about the distinction between emergency and non-emergency or elective treatment. But I think also when we practice this distinction, it's important for the doctors to be able to stand in the court of law and explain why it's considered an emergency. Just labeling as emergency is probably not good enough. And I think Vanessa points out to the fact that the court probably would not just listen to an individual's opinion, and they will actually get maybe some form of collective opinion from other peers. So yeah, I think that does change, because we have to be very realistic that when decisions have to be made very quickly in emergency setting, there would certainly have to be compromise somewhere in the thought process and also in how we deliver care to the patient.
Okay, thank you, Chun Jie. Dave, I'm not sure if you want to add something to that.
I think it's all been covered. I think that, the distinctions between emergency, urgency, elective, semi-elective, all these things are very blurred. and the professional standard will probably prevail. And again, it doesn't mean that when we say professional standard, we do not need consensus that everybody believes this is an emergency. If we have a reasonable body of people who say that, yeah, this qualifies as an emergency, that would probably would suffice. I also wanted to point out that many of these things do not have to be, set, binary decision-making processes. And even in an emergency, it also, even if she was unconscious to start with, which is not in this case, and, if she was in septic shock, for example, some of this may be that, we say it's an emergency, we start treatment, she improves a little bit, she regains some decision-making capacity. We can continue to engage with the patient during the treatment process, and we can continue to have that conversation and updating. So sometimes there may be time-sensitive decisions. You might need to give the first antibiotic, and you may not be able to have a full, in-depth discussion. You may not be able to find out from the old notes, her previous preferences and so on. And that may be reasonable to give the first dose. And then, she's a little bit better, she's a little bit more stable. Before the next dose or the subsequent dose and so on, the conversation can go on. So I just wanted to highlight that we do not need to think of these things as, moments in time which are fixed. They can be, care is an ongoing process, and we should think about the conversations with our patients also as an ongoing process. So then maybe it may be easier to think about and deal with the practical realities of medicine.
Thank you, Dave, and thank you to all the panelists for that. Professor Joseph, did you have a comment to make?
No.
Okay.
I was just adjusting. I didn't want to go into a muscular cramp.
Okay. Now we've had another question from the audience. Excellent question, of course. This one is, if the patient has early stage dementia and lapses between confusion and lucidity, would Section 37.6, this person's obviously very familiar with this, with the new law, would Section 37.6 allow for the doctor to communicate the kidney damage only to the caregiver? Right. Maybe Vanessa, do you want to take this first, and then we can ask Chunche and Dave for their sort of more clinical perspective?
Yeah, sure. Okay, so the term used in the question is caregiver, which is not really a legal term. If the patient has appointed a deputy, under the Mental Capacity Act, assuming the patient doesn't have mental capacity, or there is a donee pursuant to a LPA, then the team can communicate with the donee or the deputy, right? But if there isn't, then the duty of care is owed to the patient and the patient alone. The reason why I say, caregiver is not a recognized term, it gets very difficult when patients say, oh, you should have told my family. Because what is family, right? To some people, family means immediate family. And then to some, because they are close to the extended family, they feel that extended family should be included. So, in terms of the legal perspective, the duty of care is just owed to the patient and the patient alone, unless the patient has appointed a deputy or a donee.
Okay, now that of course raises a lot of very, very interesting questions, because the law specifically mentions the patient, and there is a provision about legal disability, right? And then the person authorized to make decisions. So interestingly then, if you do have family around, their expectation is normally to be consulted at the very least, right? Dave, would that also be your experience?
Yeah, I mean, legal decision-making aside, when patients don't have decision-making capacity, decisions need to be made in the patient's best interest. And best interest, I tell all doctors, is not limited to medical best interest. And in order to figure out all the other things that are important to the patient's values and beliefs and so on, you need to take into account information that the family members, the caregivers, and so on can give you. So essentially, best interest decision making is a consensus building process where we involve a lot of people and we try to get input, and then we put forward what should be done in their best interest. Even if the patient had a legally appointed a decision maker, if the patient's condition is serious and life-threatening, which this situation sounds like it may be, the decision-making responsibility still probably falls upon the medical team or the person who's responsible for providing medical care. So again, that doesn't mean we should do only what the medical, what's in the medical best interest. We need to talk to the person who's the legally appointed decision maker to figure out, what other important information will be needed, what the patient's previously stated wishes were, and then incorporate that together with the medical aspects of the care to put forward a best interest kind of recommendation. And again, I think it would be good practice to put this forward to the next of kin or the decision maker to see if there is any objection. And if there's any objection, rather than make this immediately a fight, to say, why is there an objection, and try and figure out if there is something that we have missed in our recommendation of what's in the best interest.
Yeah, thank you, Dave. Chunchi, I'm not sure if you have anything to add on that.
I just feel that more often than not, we don't, I think that's where the law has got to be contextualized, because it's nice if we always have a deputy or donee to speak to, but more often than not, elderly patients or with patients with dementia and they are under the care of immediate family members, it's not so clear cut. And in a case like this, I wonder if the patient has got dementia, whether the MCA, the Mental Capacity Act, will come in and complement or maybe resolve some of the issues that we can arise out of applying Section 37. Because for patients who lack mental capacity, correct me if I'm wrong, a lot of the responsibility on decision-making falls on the primary doctor looking after the patient, taking into consideration what people who are close to the patient or without the patient may have, taking input from these people, but ultimately the decision, the judgment call still falls very much on the treating physician.
Yeah, Chunchi, that's certainly the case, especially when it comes to life-sustaining treatment and treatment to prevent a serious deterioration in the patient's health. Dave, you wanted to add something.
Yes, I just wanted to build on what Chunchi has said, and I think he's brought on a really important part about mental capacity. And I think the first point that I wanted to make would be that a diagnosis of dementia in itself, not just early dementia, but just dementia in itself, does not mean that a person does not have decision-making capacity. Decision-making capacity is a functional test, and it is decision-specific. So, and as a healthcare professional, our role is not so much to decide who has capacity or is not so capacity, as to try and simplify decisions in order to promote capacity in as many people as possible, right? So that should be our default position in order to try and promote capacity. Of course, where people clearly don't have capacity and are unable to make decisions for themselves, then decisions would have to be made in their best interest. And again, we already talked about understanding the patient's wider beliefs, values, and preferences beyond just narrow biomedical interests.
Yeah, thank you, Dave. That is interesting because of the inclusive way in which the Medical Capacity Act encourages the involvement of loved ones and caregivers to express what they think the patient would have wanted in those circumstances. When we compare that with the Civil Law Act, there is no mention of family here or loved ones or anything like that. And in fact, when we're talking about the standard for medical advice, it refers specifically to information that's provided by the patient. And so what about information that's provided by close family members? What is the standing of that is perhaps something we need to think about. And I don't know whether Vanessa has an opinion to offer on that at this stage, or if it's something we should just leave out there.
Well, I think Chunchi covered the point about how ultimately it rests with the treating doctor. So, actually, I was just wondering, if there are situations where what the NOK or the family members have indicated are actually contrary to the patient's best interest, then, you know, as Trinita said, I think ultimately it does fall to the treating physician. Yeah.
Yeah, that would be an interesting conflict management situation to try and work out with the family in terms of what steps should be taken. I'd like to direct this back to a question from the audience, actually, quite an interesting one, I think. And this specifically refers to section 37(2)(a)(1), right? If we set aside the clinical note in this case, would the level of risk, right, that permanent kidney damage, kidney dialysis, would it trigger 37(2)(a)(1)? And 37(2)(a)(1), I'll just read it out because it's relatively short for everybody's, you know, so everybody can understand the context that we're talking about. Basically, what it says is that, you know, the healthcare professional should have given the patient information that a person in the same circumstances as the patient, which circumstances the healthcare professional knows or reasonably ought to know, would reasonably require to make an informed decision about whether to undergo the treatment or to follow the medical advice, right? So this is what the question is asking is, wouldn't this be information that someone would normally require, you know, your average person, in order to decide whether or not to have the treatment? So this sounds, let me, I'm not sure whether Trinita, you might want to take this first, and then we'll ask Vanessa for her legal opinion.
Okay, maybe would it be okay if I ask Vanessa to start the legal? Yeah, I think I always find it easier for me to hear what the legal, side.
Yeah, it's a bit tricky because so the provision says information that a person in the same circumstances as the patient. So in the case scenario, the circumstances are that it's life-saving, and also that this patient has expressed certain vague interest in, you know, which have been recorded in the medical records. Unfortunately, I don't think I have a direct answer. I think it's very much arguable. Yeah. And it's back to the discussion we had earlier about, because what is stated in the medical records were a bit vague. So, you know, it's whether how the doctors would interpret that.
Yeah, I think the question is asking from the context is, even if you didn't have the note.
Right? Okay.
Wouldn't this be information that an ordinary, reasonable patient might want? You know, to know that the medication could potentially cause them kidney damage and have lifelong dialysis.
Yeah, then I would say yes. Yeah, I mean, of course, from a legal perspective, it's very easy to say, if in doubt, disclose, right? If in doubt, more information is better. But of course, and then we say no information dumping. But, you know, this sort of long-term, as I said earlier, under Hitchcock, it is something that you would disclose. And I do think even with Section 37, there would be some guidance taken from what the Court of Appeal had said in Hitchcock. So I think it would need to be disclosed.
Yeah, so because we are having a series of questions come through in the Q&A, I think, you know, people are concerned about or are curious, would like to understand the disclosure requirements in relation to so-called emergency cases, right? Because, as I said, emergency can mean a number of things. And then we've talked about, you know, the peer professional opinion being what emergency might be and how contextual it could be. Maybe, and again, I don't mean to put anybody on the spot, but just to give some sort of clarity, or try to give some clarity to the audience here. Let's say, yes, it is, obviously this lady's in a very serious situation, but let's say we can safely wait 6 hours before we start administering the antibiotics. Would it be something you would disclose, Dave?
Well, you know, the simple answer to that is it depends, and that's not a cop out, because I think it does depend, and I think that there's a reason why your audience asked the question in this way, even regarding the clinical note, because it is about a person in the same circumstances as the patient. Right. So if this was an elective situation based on severity and probability, I would say absolutely you should disclose, and you should explain what renal failure is, and possibility of dialysis and the implications of it, so that people understand the information. But a patient who is septic and who is unwell, possibly confused, even if you had some time to explain, there are so many other things that you need to weigh up. This patient could go into renal failure from their sepsis alone. I think I could make an argument that this is not necessary to be disclosed at that point in time, right? And as I said before, these things do not need to be a single decision. At that point, you may not need to disclose it. Give the antibiotic, get the patient better. Then, before you give the next dose and the subsequent doses and the subsequent discussions with the patient, you get more information. You can, patient is a bit better, you'll be able to have a fuller discussion with the patient. So I had a discussion, we had a discussion with Prof. Roy Joseph about this earlier, and I've come around to his way of thinking that I think that I can make a strong argument that at that point of sepsis, it is reasonable to give the antibiotic first, and then subsequently bring the patient up to speed with all the implications.
Right. So, David, sounding like obviously the clinical judgment is a very important component about deciding, or important factor rather, about deciding whether or not disclosure or the type of disclosure is relevant at that point. So it really does require understanding the context very well and judging how much of an emergency that situation is before determining how. So it's not a zero-sum game, right? It depends on how you would move forward. I'm glad you mentioned this, because it kind of links us into this question. This might be the last question we take on case 2. This person is asked, and thank you for the question, does the disclosure requirement change if informing about renal failure risks is normally unlikely to make the patient or the next of kin decline the life-saving antibiotic treatment? Ooh. Dave, Chun-Chen, maybe one of you would like to take this?
Do you want to go, Chun-Chen, or do you want me to say something?
I'm just trying to process this question.
Maybe I'll say something, and then you
sure.
correct me if I'm wrong. I think rather than directly answering this question, which I'll leave to Chun-Chen, I just wanted to say that Hitchcock and Section 37 and so on should not paralyze medical decision making. We shouldn't go approach every patient as, oh my gosh, what is the legal standard here? What do I need to say in order to avoid litigation? We should practice medicine first. I mean, the point of all of these teaching sessions that we are doing at centers and so on is to tell people how to have good risk management, right? To understand the law, understand the limits, and also to understand what actually the law is trying to do. That law is telling us that we need to have ongoing communication with our patients. We need to give them information such that they can make decisions which are not only about the physical or the medical side of things. It is about making decisions in the context of their own lives. That essentially is what the law wants. The law wants us to take seriously the subjective experience of illness. So if every time we have a septic patient and I've got to think about intravenous antibiotics have a lot more complications and side effects than just renal damage. If we have to think about this and say, oh, I've got to go and tell the patient or the next of kin about all of this, rather than explain to them what exactly is happening and how we're going to stabilize their condition, that is going to paralyze medical practice. And I cannot imagine that is what was intended. So my advice to people is practice good medicine. As Prof. Roy said earlier, we need to practice way above Section 37. We need to practice medicine. And then we think that, there are some risk management issues, there are some communication issues, there are some documentation issues that we shouldn't be lazy about, completing. We should go ahead and also complete those things. And that will ensure that our patients are safe and, our practice is also safe.
Yes, thank you, Dave, for bringing the bigger picture in all of this, right? The law is just one component or one aspect of the things that need to be considered here. There are lots of ethical issues to be considered and patient safety and best interest issues to be considered as well in terms of how we manage and care for our patients, and of course, by extension, their family members. Okay, we are a couple of minutes out before we take a little break and then shift gears to the next case. I don't know if Vanessa or Chunxia or Roy, you'd like to add any comments?
I think maybe I'll just like to add on to what Dave said. I think, Sumi, you mentioned previously that you raised the question of whether emergency is a sliding scale rather than being an absolute binary kind of consideration. And I think this disclosure itself is also, I would liken it to being a sliding scale. And where the lever stops, it depends on very much on what impression the doctor has obtained after discussing with the family or the next of kin. So I think that unfortunately I don't really have an absolute answer, even to your question about whether if there's a span of 6 hours, whether how much disclosure is to be made. But I do personally, I do feel that what Dave pointed out earlier is quite relevant in that an emergency is not there forever. This basis of proceeding on being an emergency treatment, it is not something that is indefinite. So when there's any improvement in the condition, the patient is stabilized, I think the doctor should always be mindful of that and continue to make attempts to engage the family or even the patient if the conscious level is deemed adequate enough to make a decision. Ultimately, it's about the balance between autonomy and what the doctor's duty of care is and the kind of prescription, any kind of treatment that the doctor would like to prescribe to the patient.